Assalamualaikum people. Our journey along the gastrointestinal tract comes to a dead end. This is an obstruction ahead. Intestinal obstruction in its entirety is a large subject, and this lecture has been recorded in two parts. Today we will be learning something about the types, clinical features, causes, and treatment for intestinal obstruction. Since different types of intestinal obstruction share common features, this lecture discusses them along these lines here. Now, 8 to 9 liters of fluid enter the small intestine daily. Most of this volume consists of salivary, gastric, biliary, pancreatic, and intestinal secretions. Under normal conditions, the small intestine absorbs over 80% of this fluid, leaving approximately 1.5 liter to enter the colon, where the water is very efficiently absorbed around 90%, just leaving 150 ml to be excreted in the stools. Intestinal obstruction is characterized by the impairment in the normal flow of intraluminal contents and can be divided into mechanical obstruction and paralytic IDS. Mechanical obstruction implies an extrinsic or intrinsic obstacle that prevents the arboreal progression of the intestinal contents, and it may be complete or partial. Simple obstruction occludes the lumen only. Obstruction with strangulation impairs the blood supply also and leads to necrosis of the intestinal wall. Paralytic or adynamic IDS, as it's also known, is due to a neurogenic failure of the peristalsis to propel the intestinal contents with no mechanical obstruction. Adhesions make up the largest chunk of patients, with inflammatory and malignant causes coming in at second. Hernias, fecal impactions, pseudo-obstruction, and miscellaneous causes make up the rest. The cause of mechanical obstruction can be divided into three groups according to the relationship to the intestinal wall: extrinsic, intramural, it could be an annular intramural, or intraluminal. The three most common etiologies are intra-abdominal adhesions, hernias, and neoplasms. Adynamic obstruction may be a paralytic IDS, mainly involving the ileum, but can involve the colon. Here we see an IDS after an open cholecystectomy. Note the clips here and note the small bowel in the middle of the X-ray. And a pseudo-obstruction confined to the colon alone, usually the right, as you can see over here. Okay. Now, irrespective of etiology or acuteness of onset, in dynamic, which is mechanical obstruction, and the bowel proximal to the obstruction dilates and the bowel below the obstruction exhibits normal peristalsis and absorption until it becomes empty and collapses. Initially, proximal peristalsis is increased in an attempt to overcome the obstruction. That is why the augmented bowel sounds. If the obstruction is not relieved, the bowel continues to dilate. Ultimately, there is a reduction in the peristaltic strength, resulting in flaccidity and paralysis. The distension proximal to an obstruction is caused by two factors: gas. There is a significant overgrowth of both aerobic and anaerobic organisms, resulting in a considerable production of gas. I'll do a diagram here. So we've got this bowel here which is obstructed, and the bowel distal has emptied, and we've got this food here, and and these bacteria, the rods and gram-negative rods and gram-positive aerobics and anaerobes, they produce gas, and this gas is going to cause distension. Then there is the fluid. This fluid is made up of the various digestive juices, and then also the fluid that the patient has taken and the food, and this also accumulates in the gut lumen as absorption by the obstructed gut is retarded. So dehydration and electrolyte in intestinal obstruction are due to, number one, the reduced oral intake, number two, the defective intestinal absorption, then the losses resulting as a result of vomiting, sequestration in the bowel lumen, and a transduction of fluid into the peritoneal cavity outside. Okay. Now, because of its potential for a significant morbidity and mortality, prompt diagnosis of strangulation of the bowel is important. Generally, intestinal obstruction is not immediate life-threatening unless there is a superimposed strangulation. When strangulation occurs, the blood supply is compromised and the bowel becomes ischemic. Ischemia from direct pressure on the bowel from a constricting band such as a hernial orifice is very easy to understand, just simple pressure. But distension of the obstructed segment of bowel results in high pressures within the bowel wall itself. So this can happen when only a part of the bowel or the wall is obstructed, as seen in Richter's hernia. When this happens, the venous return is compromised before the arterial supply, and the resultant increase in capillary pressure leads to an impaired local perfusion, and once the arterial supply is impaired, hemorrhagic infarction occurs. Let me do another diagram here. So here we have the bowel wall. Okay, let me do it in another color. We'll do it in green. So this is the bowel, and this is obstructed here, and we've got these veins here. Okay, and these veins, the gas produced is compressing these veins. So once these veins are compressed hard enough, the blood flow stops flowing through the veins. We know that the veins are very thin. Once the blood flow stops flowing here, it builds up, the pressure, back pressure backs up and into the arterioles and stops the blood from entering into the capillary beds, resulting in an ischemia of the bowel wall, the mucosa, and then resulting in a hemorrhagic infarction. So as the viability of the bowel wall is compromised, there is also translocation of these bacteria. I'll do them in yellow, and they enter into the bloodstream and also into the peritoneal cavity due to translocation. So there is a systemic exposure to the anaerobic organisms and then the endotoxins. So the morbidity and mortality associated with strangulation are basically dependent on the duration of the ischemia and its extent. The longer the duration, the greater the exposure. Elderly patients and those with comorbids are more vulnerable to its effects. Although in strangulated external hernias, the segment involved is often short, any length of ischemic bowel can cause significant systemic effects secondary to sepsis. When bowel involvement is extensive, circulatory failure is common. So a large bowel leg segment allows a large amount of endotoxins to reach the circulation and result in circulatory failure. Now we come to closed loop obstruction. This occurs when the bowel is obstructed at both the proximal and the distal points. So this point here and this point here, it's obstructed by this band here, and the distension is principally confined to this closed loop, and it's closed because it has no influx or outflow. Okay, the distension proximal to the obstructed segment is also not very marked. A classic form of a closed loop obstruction is seen in the presence of a malignant stricture of the colon with a competent ileocecal valve. This is present in around 1/3 of the individuals. So 1/3 of the individuals have competent ileocecal valves. Now this can occur with lesions as far distally as the rectum. So it's the transverse colon, the descending colon, sigmoid, and rectum. Now the inability of the distended colon to decompress itself into the small bowel results in an increase in the luminal pressure, and this is greatest at the cecum. The cecum has a thinner wall. Now here there is this impairment of the blood flow in the wall, and unrelieved this would result in a necrosis and perforation. Mechanical obstruction has varied causes that need to be dealt with separately. Internal herniation occurs when a portion of the small intestine becomes entrapped in one of the retroperitoneal fossae or in a congenital mesenteric defect. Internal herniation is rare and can occur in the foramen of Winslow, a defect in the mesentery, mesocolon, or the broad ligament. Congenital or acquired diaphragmatic hernia, I've done too, and the fossae around the duodenum, cecum, and sigmoid are also other places where this bowel can get stuck. Now internal herniation in the absence of adhesions is a rare, and a preoperative diagnosis is unusual. The standard treatment of an obstructed hernia is to release the constricting agent by division. This cannot be undertaken generally in cases of internal herniation excuse me, as major blood vessels run in the edge of the constricting ring. So the distended loop in such circumstances is decompressed first, trying to minimize the contamination, and then reduced. So this was the loop, and this doesn't look very healthy to me though. Now this was decompressed and it has been reduced through this hole, and this will be closed later on. Now, small bowel strictures usually occur secondary to tuberculosis or Crohn's disease. Malignant strictures associated with lymphoma are uncommon, whereas carcinoma and sarcoma are rare. Presentation is usually subacute or chronic. Standard surgical management consists of a resection and an anastomosis. Generally, the stricture starts as a large stricture, then gradual narrowing. So that's why the chronic course of the disease. Now, resection is important because we need the histopathological diagnosis. In Crohn's disease, we could do a stricturoplasty if there are multiple short strictures without active sepsis. Bolus obstruction in the small bowel may be caused by gallstones, food, trichobezoars, phytobezoars, stercoliths, and worms. Gallstone obstruction tends to occur in the elderly, second to erosion of a large gallstone directly through the gallbladder into the duodenum. So let me do a diagram here. I like doing diagrams, you know, guys. So here we have the duodenum, and I'll do the greeny thing, stone, and this stone, because of its constant pressure on the fundus, usually from here, it's here, or it could also be from this area as well. Anyhow, it erodes into the duodenum and passes through the duodenum. It's quite wide, the jejunum is quite wide, and then it is impacted classically at around 60 centimeter proximal to the ileocecal valve. Now, these patients may have recurrent attacks as this obstruction is frequently incomplete or relapsing as a result of a ball valve effect. Essentially, what happens is that here we have the bowel, and here we have got the stone. Now, the stone comes in here, it obstructs, and then once the bowel dilates, the stone falls away from the obstruction, and the food starts reflowing, and then this cycle is repeated. So this is the ball valve effect. The ball moves here and then it moves here. That is the ball valve effect. Okay, so now let me clean up this one. Right now, the characteristic radiological sign of a gallstone ileus is a Rigler's triad comprising of a small bowel obstruction, pneumobilia, and an atypical mineral shadow on radiographs of the abdomen. So here we can see this is a very nicely outlined CVD and hepatic ducts, the right and left hepatic ducts, the intestines that are dilated, and then we got this stone here. Okay, the presence of two of these radiological signs is considered pathognomic of gallstone ileus and is encountered in around 40 to 50% of the cases. At a laparotomy, the stone is milked proximally away from the site of impaction. We don't want to open there because the bowel is damaged already there. We don't want to damage further, and it may be possible to crush the stone within the normal bowel lumen. If not, the intestine is opened, and at this point and the gallstone is removed. We could have food bolus obstruction, which usually occurs after partial or total gastrectomy when unchewed articles can pass directly into the small bowel. Fruit and vegetables are particularly liable to cause obstruction. The management is similar to that for gallstones, with intraluminal crushing usually being successful. Trichobezoars and phytobezoars, tricho from here and phyto from vegetables, are firm masses of undigested hairballs and fruit vegetable fibers, and when possible these lesions again are needed either into the cecum or they are taken out through an enterotomy. Stercoliths are found in jejunal diverticula or ileal strictures, and their presentation and management are identical to that of gallstones. Ascaris lumbricoides may cause low small bowel obstruction, particularly in children. An attack may follow the initiation of an anti-helminthic therapy. Debility is frequently out of proportion to that produced by the obstruction. The worms may be seen in the stool or vomitus, not a pretty sight. The diagnosis may be indicated by the eosinophilia or the sight of worms within gas-filled small bowel loops on a plain X-ray. At a laparotomy, it may be possible to knead the tangled mass into the cecum, from where the mass is easily passed through the anus, or if it not removed, then it has to be removed. Occasionally, worms may cause a perforation and peritonitis, especially if the enteric wall is weakened by such conditions as amebiasis, which again is common in these areas. In Western countries where abdominal operations are common, adhesions and bands are the most common cause of intestinal obstruction. Adhesions start to form within hours of abdominal surgery. In the early postoperative period, the onset of such a mechanical obstruction may be difficult to differentiate from a paralytic ileus. Here we can see the small bowel, this is the small bowel here, and a band of omentum stuck to the parietes in this laparoscopic view. Any source of peritoneal irritation results in local fibrin production, which produces adhesions between the pores surfaces. Early fibrinous adhesions may disappear when the cause is removed, or they may become vascularized and be replaced by mature fibrous tissue. Numerous substances have been instilled in the peritoneal cavity in the hope of preventing adhesion formation. They include hyaluronidase, hydrocortisone, silicone, dextran. It was fashionable when I was doing my residency. Chondroitin, streptomycin, anticoagulants, antihistamines, NSAIDs, and streptokinase. Not one works fully, but with the widespread use of laparoscopic surgery, the incidence of intra-abdominal adhesions would reduce. Now, adhesions may be classified into various types by virtue of whether they are early, which is fibrinous, or late, fibrous, by the underlying histology. From a practical point perspective, there are only two types, just easy, the flimsy ones, and the difficult, dense ones. Postoperative adhesions giving rise to intestinal obstruction usually involve the lower small bowel and almost never involve the large bowel. Now, one band is enough to cause an obstruction. This may be an obliterated vitellointestinal duct or a string band following a previous bacterial peritonitis. A portion of the greater omentum, usually adherent to the parietes, but to the other structures, can also cause an obstruction. Here we see a band here, and this is between the two loops of the bowel wall. So if we had a loop of intestine, just get in here, and this could always easily become obstructed. Intussusception occurs when one segment of the intestine telescopes into another, causing an intestinal obstruction. Although intussusception can occur anywhere in the gastrointestinal tract, it usually occurs at the junction of the small and the large intestines. Intussusception is encountered most commonly in children, with a peak incidence between 5 and 10 months of age, and 90% are idiopathic, but there might be an associated upper respiratory tract infection. Hyperplasia of the Peyer's patches in the terminal ileum may also be the initiating cause. As maternal decrease in the common viral infections can also result in the pathogenesis of intussusception. Now, children with intussusception associated with the pathological lead points such as a Meckel's diverticulum, polyp or duplication, or Henoch-Schönlein line purpura or appendix are usually older than those with idiopathic disease. After the age of 2 years, a pathological lead point is found in at least 1/3 of affected children. Adult cases are invariably associated with a lead point, which is usually a polyp, for example in Peutz-Jeghers syndrome, a submucosal lipoma, or other tumor. Here this is a picture of an ileocolic obstruction, intussusception before reduction, and after the reduction you can see that there is a severe hemorrhagic infarction in this bowel. Bowel is perfectly okay. Now, an intussusception is composed of 3 parts: the entering or the inner tube, which is called the intussusceptum, this one; the returning, the middle tube, which has no name; and the sheath or the outer tube that is called the intussussapiens. The part that advances is the apex here, and if there is a lead point, it will be here. And the neck is the junction of the entering layer with the mass, so the neck is over here. Now, intussusception may be anatomically defined according to the site and extent of the invagination. In most children, the intussusception is ileocolic. In adults, colocolic intussusception is more common, and the degree of the ischemia is dependent on the tightness of the invagination, which is basically the neck, you see. And this is usually greatest as it passes through the ileocecal valve, because it's a valve and it causes constriction. On a CT scan, a target sign, an intestine within an intestine, if present, is pathognomic of a intussusception. Now, once the bowel telescopes, the blood vessels are trapped between the layers with a decrease in the blood flow. The ischemia results in edema, which further decreases the blood flow. So the blood flow is basically compromised here at the neck. Here you can see this is the intussusceptions, okay, the intussusceptum and the spectrum, sorry, and this is the neck. So this is a rather wide neck in this patient. Now, a volvulus is a twisting or axial rotation of a portion of bowel about its mesentery. The rotation causes obstruction to the lumen if it is more than 180 degrees, and if it is tight enough, it can also cause vascular obstruction, occlusion, when it has torted more than 360 degrees. Now, the bacterial fermentation adds to this distension, this seen here, and the increasing intraluminal pressure impairs the capillary perfusion. The mesenteric veins also become obstructed as a result of the mechanical twisting, and the thrombosis results and contributes to the ischemia. So basically, it is a venous ischemia. Okay. Now, volvuli may be primary or secondary. The primary form occurs secondary to congenital malrotation of the gut, abnormal mesenteric attachments, or congenital bands. Examples include volvulus neonatorum, cecal volvulus, and a sigmoid volvulus. A secondary volvulus, which is the more common variety, is due to the rotation of a segment of bowel around an acquired adhesion. So if there were adhesion here and it had torted, so that would be a secondary volvulus. This is a large, this one is a typical appearance of a sigmoid volvulus, and this is a tire tube appearance, right? Now, the rotation in case of a sigmoid volvulus is always in an anti-clockwise direction. In a cecal volvulus, it is clockwise. The predisposing causes are a narrow attachment of the pelvic mesocolon, seen here, or a long pelvic mesocolon, an overloaded sigmoid, or a band. Okay. Other predisposing factors include high residue diet and constipation. The condition is most often seen in elderly patients with a chronic constipation. Comorbids are common, and chronic psychotropic drug is also use is also associated with this condition. Younger patients present early, and the prognosis is inversely related to the duration of the symptoms. So the longer the duration, the worse the symptoms, the worse the prognosis, better the prognosis. Sorry. Now, presentation can be classified as fulminant with a sudden onset, severe pain, early vomiting, rapidly deteriorating clinical course, and an indolent one with an insidious course, slow progressive course, and less pain and less vomiting. This is a rare condition, also known as the iliosigmoid knotting, and the long pelvic mesocolon allows the ileum to twist around the sigmoid. And here we can see the twist, and this is the sigmoid here, and it can result in gangrene of either or both segments of the bowel. The patient presents with acute intestinal obstruction, but the distension is comparatively mild. Plain radiography reveals distended ileal loops and a distended sigmoid colon. At operation, decompression, dissection, and anastomosis are required. Coming to clinical features, the diagnosis of dynamic intestinal obstruction is based on the classic quartet of pain, distension, vomiting, and absolute constipation or obstipation. Obstruction may be classified clinically into two types: small bowel obstruction, it could be high, middle, or low, and large bowel obstruction. The nature of the presentation will also be influenced by whether the obstruction is complete or incomplete. A complete small bowel obstruction has all the cardinal features, the classical quartet. In cases of complete large bowel obstruction, there is often a surprising lack of preceding symptoms. Both small and large bowel obstruction can present with more chronic symptoms, in which the symptoms are intermittent or the obstruction is incomplete. And an incomplete obstruction is also referred to as partial or subacute intestinal obstruction. The presentation will also be further influenced by whether the obstruction is simple, in which the blood supply is intact, or strangulating or strangulated, in which there is interference into the blood flow. Now, in high small bowel obstruction, vomiting occurs early. It's profuse and causes rapid dehydration. The distension is minimal because of the small amount of bowel that is involved. And there is little evidence of dilated small bowel loops on abdominal radiography. In middle small bowel obstruction, there is intermittent pain, moderate abdominal distension with moderate vomiting. Multiple small dilated small bowel loops are seen on abdominal radiography. So here are the loops that can be seen. And in low small bowel obstruction, pain is predominant with central distension. These bowel loops will be easily visible on the x-rays. In large bowel obstruction, distension is pronounced. Pain is less severe, and vomiting and dehydration are later features. The colon proximal to the obstruction is distended on abdominal radiography. So the small bowel will also be dilated if the ileocecal valve is incompetent, which occurs in around 2/3 of patients. So it will decompress into the small bowel, and the small bowel will be dilated. As we've seen, the clinical features vary according to the location and duration of the obstruction, the underlying pathology, and the presence or absence of intestinal ischemia. As vomiting and third space losses of fluids and electrolytes continue, later manifestations of intestinal obstruction that may be encountered include dehydration, oliguria, and hypovolemic shock. Bacterial translocation and endotoxemia also result in pyrexia and asepticemia. And the increasing intestinal distension results in increased intra-abdominal pressures, which is putting pressure on the diaphragm, resulting in respiratory embarrassment. In all cases of suspected intestinal obstruction, it's important that the hernial orifices must always be examined. Okay. Now, pain is the first symptom encountered. It generally occurs suddenly. It is severe in nature. It is colicky, usually centered on the umbilicus, in the small bowel for small bowel, and for the large bowel, as we said earlier, middle of the abdomen. And this pain coincides with the increased peristaltic activity. With increasing distension, the colicky pain is replaced by a mild and more constant diffuse pain. If there is no ischemia and the obstruction persists over several days, the pain reduces and can disappear. The development of severe pain is suggestive of the presence of strangulation. Remember that, especially if that severe pain is continuous. And you should be aware of that patient whose pain is not controlled by intravenous opiates is in severe pain. Now, colic pain may not be a significant feature in postoperative simple mechanical obstruction, and pain does not usually occur in paralytic ileus. Now, the more distal the obstruction, the longer the interval between the onset of symptoms and the appearance of nausea and vomiting. As obstruction progresses, the character of the vomitus alters from simple digested food initially to feculent material as a result of the presence of enteric bacterial overgrowth. So, in the small bowel, the degree of distension is dependent on the site of the obstruction and is greater the more distal the lesion. Now, visible peristalsis may be present. So you can see this visible peristalsis in this classic diagram from Bailey and Love, and here is the lesion that has caused this visible peristalsis, that is a hernia. Now, this visible peristalsis can be provoked by flicking the abdomen. You just flick it with your finger. Distension is a later feature in colonic obstruction. Constipation may be classified as absolute, that is, neither feces nor flatus is passed, or relative, where only flatus is passed. Absolute constipation is a cardinal feature of complete intestinal obstruction. Some patients may pass flatus or feces after the onset of obstruction as a result of the evacuation of the distal bowel contents. The administration of enemas should be avoided in cases of suspected obstruction. This just simply stimulates the evacuation of the bowel contents that are distal to the obstruction and confuses the clinical picture. So you got this obstructed bowel, and there are feces here, and then this is obstruction, and then there are feces here, and you give an enema, these feces come out, and you think, oh, he's passing stools, but that's not the case. He still has an obstruction here. So the rule that the absolute constipation is present in intestinal obstruction also does not apply in patients with Richter's hernia and gallstone ileus, as I said before, because of the ball effect, the mesenteric vascular occlusion, functional obstruction associated with pelvic abscesses, and all cases of partial obstruction in which in fact you might have diarrhea. Now, dehydration is seen most commonly in small bowel obstruction because of the repeated vomiting and fluid sequestration. This fluid sequestration in the small bowel is called third space losses. It's third spacing. It results in dry skin and tongue, poor venous filling, and sunken eyes with oliguria. The blood urea level and hematocrit rise, giving rise to a secondary polycythemia. Hypokalemia is not a common feature in simple mechanical obstruction. An increase in serum potassium, amylase or lactate dehydrogenase, they may be associated with the presence of strangulation, as may a leukocytosis or a leukopenia. Pyrexia in the presence of obstruction is rare, and it may indicate that one, there is ischemia, number two, there is an intestinal perforation or inflammation or abscess which is associated with the obstructive disease, such as like if you have a perforated appendix, appendicular abscess causing obstruction. Now, hypothermia indicates septicemic shock or a neglected case of long duration. Localized tenderness indicates impending or established ischemia. The development of peritonism or peritonitis indicates impending or overt infarction or perforation. And in cases of large bowel obstruction, it is important to elicit these findings in the right iliac fossa, as the cecum is the most vulnerable to ischemia, as we discussed earlier. Now, high-pitched bowel sounds are present in the vast majority of patients with intestinal obstruction. Normal bowel sounds do not rule out obstructions. Bowel sounds may be scanty or absent if the obstruction is long-standing and the small bowel has become inactive. It is vital to distinguish strangulating from non-strangulating intestinal obstruction because the former is a surgical emergency. The diagnosis is almost entirely clinical. The presence of shock suggests underlying ischemia, especially if the shock is resistant to simple fluid resuscitation. In impending or established strangulation, pain is never completely absent. The patient complains of continuous pain. The presence and end character of any localized local tenderness are of great significance. So if there's a bowel loop there, you would have localized tenderness. Mild tenderness, if there is mild tenderness, you need to frequently reassess these patients. Now, generalized tenderness and the presence of rigidity indicate the need for an early laparotomy. And in cases of intestinal obstruction in which pain persists despite conservative management, even in the absence of those signs, just simple pain, strangulation should be presumed. And when strangulation occurs, especially in an external hernia, the lump is tense, tender and irreducible, and there is no cough, expansile cough impulse. Skin changes with the erythema or purplish discoloration are also associated with the underlying ischemia. You can see this is all this purplish discoloration in this hernia. Now, the classical presentation of intussusception is with episodes of screaming and drawing up of the legs in a previously well male child. The attacks last for a few minutes and recur repeatedly. During the attacks, the child is listless and pale. Vomiting may not occur early, but later on it becomes conspicuous and is bile stained. And initially the stools may be normal, but later on you have this classic red currant jelly stools when blood and mucus are evacuated. So whenever possible, we try to examine the patient, the child, during the episodes of colic without disturbing the child. That's when you can see the at the abdomen. So classically the abdomen is not initially distended. You could feel a lump that hardens on palpation. That's the intestine, and this is parental around in 60% of cases. And the lump would be a sausage-shaped lump. Okay, and there is this associated feeling of emptiness in the right iliac fossa here, as the bowel has moved to this side here, and this is for the sign of dance. On rectal examination, blood-stained mucus may be found on the finger. Occasionally, if there is an extensive ileocolic or colocolic intussusception, the apex may be palpable or even protrude from the anus. Unrelieved progressive dehydration and abdominal distension from small bowel obstruction will occur, and this would be followed by peritonitis secondary to the gangrene. Very rarely a natural cure may occur as a result of the sloughing of the intussusception, and that would be a wonderful event. Now, cecal volvulus is clockwise, and it may occur as part of a volvulus neonaterum or de novo, and is more common in females in the 4th and 5th decades, and usually presents acutely with classic features of obstruction. Ischemia is common. At first, the obstruction may be partial with the passage of flatus and feces. In 25% of cases, examination may reveal a palpable tympanic swelling in the midline or left side of the abdomen. So it's the abdomen is here, and this swelling is going to go, and if the cecum normally stays here, then it moves towards the left and towards the left upper quadrant. Okay. The volvulus, commonly it's in the left upper quadrant. The diagnosis is again usually not made preoperatively. A sigmoid volvulus presents with symptoms of large bowel obstruction. The presentation varies in severity and acuteness. Younger patients appear to develop the more acute form. Abdominal distension is an early and progressive sign, which may be associated with hiccough and retching. Again, the large tire tube, as we saw before, that is compressing the diaphragm and causing the hiccough and the retching. Constipation is absolute, obviously. In the elderly, a more chronic form may be seen. In thin patients, the grossly distended, torted left colon is visible through the abdominal wall. Now, this concludes the first part of this 2-part lecture on intestinal obstruction. Allah Hafiz and stay safe.